and how to implement these strategies today, even in our current environment with our insurance companies. So, SMART or MART, single maintenance and reliever therapy. This is basically using a specific type of inhaler, combination of inhaled steroid and formoterol. The studies have specifically been used with budesonide and formoterol. That combination has been the most well studied. This is your Symbicort. This is your Breyna. The reason why it has to be formoterol and not another long-acting beta agonist, because formoterol, the onset of action is similar to albuterol, is rapid acting, so it can actually provide more quick relief than other forms of long-acting beta agonists. Dulera also has formoterol. The inhaled steroid mometasone in Dulera has not been specifically studied when it comes to MART therapy, but the guidelines, at least the GINA 24 guidelines, the Global Initiative for Asthma guidelines, do say it can be a substitute as well. Just know that it has not been officially, quote unquote, studied for the use of SMART. The combination medications that are not capable of doing SMART are Advair, Wixel, which is pretty much a generic version of Advair, or Breo. All these contain a long-acting beta agonist that has a slower onset of action and therefore is not suitable to be used for relief of symptoms. Another definition, we're going to go over anti-inflammatory reliever therapy, AIR therapy. This is just ICS formoterol as needed, not using daily, just strictly using a different inhaler to replace your albuterol. And we're going to talk a little bit more about this because I feel like this is something that I can actually more readily put into practice right now. So why is ICS formoterol better than using albuterol? We kind of have more and more evidence that when patients are having an asthma attack, it's not just the bronchospasm that's the issue. It's not just the muscle squeezing down around the bronchioles that just need to be relaxed. What we also see that there's this increase in inflammation in the lungs as well that's not being treated with albuterol. So you have these, not only have these muscle squeezing, but you have these airways that are inflamed, maybe even full of little mucus. The lumen of those airways are a little bit more narrow due to that inflammation. And you can relax those muscles all you want with albuterol, but the airway itself is still inflamed, swollen, boggy. These patients are going to have issues. And so what the evidence kind of pointing towards is that if we use inhaled steroid with the long-acting beta agonists, such as formoterol, in these acute settings, you'll be better able to prevent severe exacerbation that requires steroids, emergency visits, or hospitalizations. Get a little feedback here. Okay, perfect. Thank you. And so it seems like asthma management is slowly moving away from albuterol, slowly meaning that it is being adopted in other parts of the world, hasn't been adopted here yet, even other parts of Europe hasn't been adopted yet, but there's becoming more and more evidence to show that albuterol isn't the way to go for pretty much anyone with asthma. So this is from the GINA guidelines. This is kind of step-up therapy. We're going to focus right now on steps 1 and 2 for your teenagers up to adulthood. And what we see is steps 1 and 2. So this is your intermittent asthmatics and maybe your mild persistent asthmatics. What's actually recommended now, instead of albuterol as needed or even a low-dose inhaled steroid, what's recommended is as needed low-dose inhaled steroid formoterol. So as needed low-dose Symbicort, Breyna is the other generic. And so this is a big difference than what we've been used to before. This is something I think you can readily implement into your practice. Basically, all your teenagers who have mild intermittent asthma or maybe on a low-dose inhaled steroid, the evidence shows that these patients should be converted to using just Symbicort as needed for their symptoms. So what this would look like is 1 to 2 puffs of Symbicort, the higher dose, the 160, as needed, up to 12 puffs in one day, no more than 6 puffs at one time. There isn't any kind of guidance on how, if they need to space this out or anything. Basically, I just tell my patients, take 1 puff, see how you feel, wait a few minutes. If you're still feeling some tightness, coughing, wheezing, go ahead and give yourself another puff. and so on, up to 6 puffs at one time, but no more than 12 puffs total in one day. When you compare this to just using albuterol as needed, you see a huge reduction in the amount of emergency room visits and hospitalizations by 65%, reduced need for oral corticosteroids by over 55%, by over 50%. If you compare just using this as needed to being on a daily low dose, inhaled steroid and as needed albuterol, there's not as a robust improvement, but there's still a significant difference in the need for emergency visit or hospitalizations for these patients. And now you may be worried about, wow, we're giving inhaled steroids as needed now. That's a lot more inhaled steroids than someone would give. They're just using albuterol. But still, compared to being on a daily inhaled steroid, is a significant increase overall in their inhaled steroid exposure, equivalent to 2 puffs of QVAR daily, at least is what they kind of averaged out in the studies. And that's a low dose to the point where I wouldn't, especially at this stage, I wouldn't worry about any long-term side effects, such as growth delay or whatever coming from that. It's definitely a significant improvement in quality of life. And also a significant improvement in needing oral steroids over and over again. We kind of label these patients as mild intermittent asthma, and what we've kind of been seeing is that mild is kind of not a great way to describe these kids, because even though their symptoms are not frequent, they can still have severe enough exacerbations leading to oral corticosteroids, emergency visits, or need for hospitalizations. So we're going to the GINA guidelines for 6 to 11 years old. What they recommend for your intermittent asthmatics is low-dose inhaled steroids taken whenever ASABA is taken, a short-acting beta agonist or albuterol is taken. This has been much more difficult to actually implement in everyday practice. At least in the studies, what they would do is that they would take basically a QVAR inhaler and tape it to an albuterol inhaler back to back. And so whenever they take 2 puffs of albuterol, they would take like 2 puffs of like QVAR 40. Obviously not something that's very reasonable to use in practice, just because it's burdensome. It's not, doesn't seem to be convenient for someone to carry around 2 inhalers taped back to back. And while there is good evidence to show that it is more helpful in preventing severe exacerbations than using albuterol, we just don't have anything that would actually be useful to prescribe in kids. So the only inhaled steroid short-acting beta agonist inhaler that's available in the US is something called AirSupra. It's not FDA approved for kids under 18. And actually this particular inhaled steroid albuterol inhaler was not used in the studies. I think the AirSupra is budesonide. The studies were using beclomethasone. So not technically what we're looking for. I think that they just haven't studied inhaled steroids for formoterol as needed in kids as of when they're updating the 24 guidelines for GINA. I think those studies are on their way. I think that in the probably near future, this recommendation of using inhaled steroids, short-acting beta agonist combination will eventually be replaced and be similar to what we see in our 12 years kids that are 12 years older, and where we need Symbicort as needed. So going a little further, we're going to go into actual smart therapy. So this is your step 3, step 4 in kids pretty much 5 years and older, but specifically in 12 years old and adults, it looks a little bit different. So when we look at the evidence behind smart therapy, this is kind of why we're so strongly suggesting we try this, is that at least when you compare SMART to using a higher daily dose inhaled steroid with albuterol as needed, you see a big reduction in severe exacerbation, 38% reduction in asthma exacerbation requiring emergency visits, hospitalization, or steroids. There's improved symptom scores The overall exposure to inhaled steroid dose is significantly reduced as well, up to a quarter to one half, depending on how much of an inhaled steroid dose they were on to begin with. And therefore, the best thing of all is that you have a lower risk of growth suppression in patients 4 to 11 years old. When you compare SMART to using a daily same dose inhaled steroid long-acting agonist and an as-needed albuterol, so basically you're in this equation, you're just replacing albuterol with Symbicort to be used as needed. There's still a significant reduction in severe exacerbations that require emergency visit hospitalization of steroids by 32%. So it's still a big benefit from just switching them to using Symbicort as needed to from albuterol as needed. And then finally, even if you increase their ICS LABA dose daily, but still use albuterol as needed, SMART still is better at reducing severe exacerbations, at least in adult studies. So SMART dosing, how do we do it in kids? So for step 3, step 4, when you're just beginning to go into SMART, you would do Symbicort 80 over 4.5, or this would be your Dolera 50 over 5, depending on insurance coverage. One puff once a day, and then you do one puff as needed. When you get to step 4, you actually do one puff twice daily, then one puff as needed. For kids 5 years up to 12 years old, what's recommended is to use up to 8 puffs of Symbicort daily. So if you are subtracting their one puff once or twice a day, that means they have about 6 to 7 puffs left over to be used as needed throughout the day, but no more than 4 puffs at one time. For smart dosing for kids 12 years and older, we'll be using a higher dose of Symbicort again. In step 3, you'll be using the Symbicort 160 or Dulera 100, one puff once or twice daily, and then your Symbicort as needed up to 12 puffs daily, no more than 6 puffs at one time. Steps 4 and 5, you do Symbicort 2 puffs twice daily, then one puff as needed. So the benefits of SMART: possible increased risk of growth suppression with SMART, especially in younger kids. You have decreased confusion of reliever versus controller medication, which I'm sure everyone has come across at some point where they're using albuterol twice a day, then using their fluticasone as their reliever without much benefit. And then, especially when it comes to patients who aren't really adherent, which is unfortunately a lot of kids, especially our teenagers, if they're using their ICS formoterol as their rescue, then at least they're getting some inhaled steroid in their system and having some better controller kind of benefit than if they just were using albuterol as needed and not using their daily controller. The main concern with SMART is how do we get this covered? And the bigger thing is that like insurance will only, most insurance, I haven't really found insurance that will cover more than one inhaler a month. But yeah, it seems like everyone's just doing one Symbicort inhaler per month. So you're kind of limited in how you can apply this to your daily practice. Now, is SMART safe? They have done numerous studies on this, and they've done huge doses of SMART of ICS formoterol, and overall, it seems to be actually very safe. In one study, they found that they did 10 puffs in an hour on top of doing daily of 4 puffs of the 160. So overall, 14 puffs in one day, no issues. No issues when you use 20 puffs of formoterol in 3 hours. And at least when all these studies are looking at SMART versus kind of standard therapy, there wasn't any difference in harms. Now, another question that comes up is, do patients need to rinse their mouth after every use, as we kind of advise everyone to do with inhaled steroids? At least in the studies, the answer is no. When they did smart therapy or air therapy and looked at it compared to inhaled steroids or standard therapy, there wasn't any increased risk of oral candidiasis when using smart or air therapy. What about exercise? So in that case, for our patients who have exercise symptoms, instead of using albuterol, they can use 1 puff of their ICS formoterol inhaler prior to exercise. Now, talking about how we put this in the asthma action plan, the asthma action plans as we currently see them are not suited for smart therapy. The schools themselves are probably not comfortable using smart. At some point, hopefully, we'll be able to use kind of smart more regularly. If that's the case, this is a sample asthma action plan that you would look at that would basically talk about what dose of the Symbicort they're on, how many doses they can take, and if they do a pre-exercise or not. The biggest problem that's holding insurance approval back is that even Symbicort and Dulera aren't really on board on using it as needed. This, if you go to the website today, you'll see this on Symbicort. Symbicort is not used to relieve sudden breathing problems. It will not replace a rescue inhaler, similar to Dulera has the same kind of bolded phrase in there. I think where this comes from is that in the studies that they're doing a dry powder inhaler, so kind of those inhalers that you like click and the patient breathes it in. Those formulations aren't available in the US. And so even though we have a lot of evidence that this medication will work, and I really don't think the way that it's delivered is going to affect it significantly, the FDA hasn't approved the regular Symbicort inhalers for reliever therapy. And so Symbicort and Dulera both have to kind of say on their website that these shouldn't be used as rescue. So one of the things that you need to kind of tell your parents when and if you're doing this is that they may look at this website, they may see this phrase, tell them to just ignore it, and that there's a lot of evidence that this actually works. So how to put this into practice today? So if we're limited by the fact that most, if not all, insurance will only allow us to do one controller combination inhaler per month. All right. So for all patients 12 years and older, what I would do is that if they're mild intermittent asthma or just very mild persistent asthma, go ahead, stop their albuterol and switch them over to Symbicort 160 or Dulera 100 as rescue and pre-exercise. And that's your anti-inflammatory reliever therapy. For patients who do require being on a daily controller medication, you can only really implement SMART if their asthma is being well controlled on just 1 puff twice a day of Symbicort or Dulera. If they're needing 2 puffs twice a day of either of these, there's no room to use reliever puffs because they'll run out of their inhaler early, and insurance and the pharmacy will give them a really hard time of getting their medication refilled before it's due. Kind of same thing in children 5 to 11 years old. You can consider starting SMART if they're doing Symbicort or Dulera. The lower doses, 1 puff once or twice daily. If they're needing more than that, you can't do it as of right now. As for anti-inflammatory reliever therapy in these patients, you can consider an inhaled steroid short-acting beta agonist as the GINA guidelines kind of recommend. I don't know how you're going to put that really into practice because I don't think any parent's going to want to kind of duct tape those inhalers together and put them in their kid's pocket or have the school nurse use it. I would say, even though the GINA guidelines don't recommend it, I feel like it would be reasonable to instead try Symbicort as needed as your anti-inflammatory reliever therapy before you do something like Air Supra or QVAR albuterol taped together. The one thing that you need to emphasize to patients who are going to do smart therapy is that they need to kind of stockpile these inhalers. So when their next refill is due, even if they're not out of the Symbicort or Dulera that they already have, go ahead and pick it up. All right, because what we don't want to happen is that, hey, you know what, maybe you had a really bad week, really bad month. You used a lot more of those Symbicort rescue puffs than you're used to. You run out of inhaler early and you're kind of stuck in a bind because you can't get your new Symbicort Dulera inhaler fulfilled because it's not due yet. So, in summary, both SMART and air therapy are associated with significant reduction in severe asthma exacerbations compared to using albuterol as needed with or without a daily inhaled steroid or combination inhaler. For patients 5 or 6 years and older requiring step 3 or step 4 treatment, consider SMART. For patients 12 years and older with asthma, you can consider Symbicort 160 or Dulera as needed to replace albuterol, whether or not they are on a daily controller. And these are my references. And that is the end of my talk. I'll be happy to answer questions.
Hi, Dr. Martin, it's Dr. Fugate. Thanks again for doing this. There are some headaches with this process, and I know you've been trying, and we talked about coverage before everyone else jumped on. Is there any movement out there to expand the coverage? So, because it works, and we want to use it, but again, it's about the families being able to get access to the medication.
Yeah, I haven't really heard anything. I think the big holdup is that it's FDA is being a real stickler of the delivery system because the studies use that dry powder inhaler form instead of the kind of the metered dose inhaler that we have available in the US. And so until the FDA kind of, I think, approves of Symbicort being used as a reliever therapy with the formulations we have, we're not going to get movement on it being used or approved to be used as SMART. So there's a lot of kids that what I do is that I put them on 2 puffs twice a day to start off with, see if I can get them controlled. During the summer, when they're less likely to get sick, when it's generally better to have asthma, I may drop them down to 1 puff twice a day and use SMART over the summer just to see how they like it. Right? If they do well over the summer on that therapy, then we talk about, hey, maybe we just take it month by month in the school year and see if we can continue this. But until you get your patients to tolerate using just 1 puff once or twice a day, unfortunately, yeah, you can't apply SMART right now.
Is there any concern about younger kids using the powder and their ability to breathe it in? Because I heard someone at a talk tell me once that's really hard for these kids, and you may have to get pre-authorization for them to, to get the regular inhaled steroid. Is that a problem by age?
So I think that it depends. Obviously, I think theoretically a 5-year-old could do a dry powder inhaler. Not every 5-year-old could do a dry powder inhaler. I'm lucky because I can do pulmonary function testing, and I feel like if they're able to do pulmonary function testing pretty well, then I have more confidence that they'll be able to follow the maneuvers necessary to do a dry powder inhaler. For people who don't have access to spirometry, you really just kind of have to trust your gut and say, maybe have them try it in the office, try the maneuvers, and see if you feel like they can follow directions enough to do it. I would say my rule of thumb is that most patients by the age of 7 years old could probably do a dry powder inhaler. 5 to 6 is kind of iffy. Right? But I don't really worry about that too much, fortunately, because we have Symbicort and Dulera both as inhalers. It's just become an issue when they need inhaled steroids because fluticasone sometimes isn't covered. Azonex, as far as I'm aware, is still on significant back order. And then insurance sometimes forget they take care of kids, and the first thing they want to try is like QVAR Ready Haler, or I don't know what else is out there. The budesonide inhaler as well, which aren't really suitable for kids, I would say, that are younger.
Got it. And then there's always those kids that you can't even get to sit still for 2 minutes, much less do that. So
yeah, exactly. But I think one really easy change that you can apply, at least to your teenagers, is changing them over from albuterol to their Symbicort. Now, the issue is with that is that, of course, schools aren't comfortable using Symbicort as rescue, which is why I think that it's really only in your teenage population that you can really do this, and when they can carry their own inhaler. I just kind of tell my patients, like, don't anyone know this isn't albuterol. Just keep it in your pocket, take it if you need it. But I think most schools aren't going to be like reaching the kids' pockets, taking out their inhalers, and making sure that it's albuterol, not Symbicort.
Got it. Any other questions, anybody?
Yeah, when we fill out the school asthma action plan, we need to put the name of the inhaler that the student will be carrying, and then circle will carry. So we're not going to be able to deceive the school nurse, but what we can do is we can send in a photocopy of our screenshot of one of the of algorithms that you just gave, and say, look, this is what our pediatric pulmonologists are advising. And I think that would satisfy the school nurse.
Yeah, so I mean, what I do is I put on the asthma action plan to use albuterol, but if the kid's carrying around Symbicort in their pocket, I don't think anyone's going to pat them down and make sure they're using albuterol, not Symbicort. As for this putting down Symbicort as a rescue inhaler, I think the problem you'll have there is that legally we have the websites of these companies saying that they're not supposed to be used as reliever therapy. I don't know if the schools are wanting, even with saying that the doctor says that this can be used as reliever therapy, I don't know if the schools will still be comfortable using something when the medication company's own website saying that they shouldn't be used as reliever therapy.
Any other questions, guys? Well, I think did someone have a question? No. Well, there's definitely barriers, and we know the medication works, and it works well for kids. It's just very frustrating that the FDA and everybody else can't jump on board to make the change so that we can make this work. And when it comes to these value-based care measures and what they're pushing us to do, it's our hands are tied if things, if they can't use it at school, or they can't do this in the age group. So we can do the best we can, and we can definitely find a population that can benefit from this.
Yeah, I agree. I think. Sorry, go ahead.
Yeah, I had a quick question about the insurance, because like if you have a kid on the smart therapy, but then we have to have them use albuterol at school, will the insurance pay for the Symbicort and the single albuterol for the school?
Yeah, because as far as insurance knows, you're not using the Symbicort as smart. You're just using the albuterol as needed. What you can do, and I've been doing more often, is when I first started Patient on Smart, I sent a 3-month supply. All right, so they already have like their daily inhaler and also a couple like stockpiled away. And I think that's probably a better way to start implementing Smart than doing 1-month supply. So then they can get kind of behind sometimes. All right, but yeah, I do 3-month supplies, Symbicort inhaler.
I think he froze.
Yes, he definitely froze. Dr. Martin, you froze for a second.
3 to 4 hours. Okay, sorry. So,
Dr. Martin, can you repeat that?
Yeah. Thank you.
Yeah, so you still need to have the albuterol on hand in case they may have a very terrible day. They may kind of reach their maximum amount of daily puffs on their Symbicort. And after that, they may need to use their albuterol. Or, who knows, maybe they don't have their Symbicort inhaler on hand. They may just have albuterol. I think it's good. They still need albuterol, I think, as a backup just in case. So we're not ready to get rid of albuterol completely, but I think we're getting rid of albuterol as a first-line medication for relief in patients with asthma.
Okay, thanks.
Any other questions, guys? I'm hoping we can share this video for a bit. I don't know what that would mean for you guys, but if that would be possible, that would be fantastic. We really, truly appreciate your time, and we will get there. We hope we will get there, and eventually, okay. I'm sorry. Do you use a spacer? I'm sorry, it was in the chat.
Yeah.
I'll look it up.
Yeah, for these,
Yeah.
for
Use a
Dulera and
spacer with
Symbicort,
Symbicort.
we'll need to use a spacer for it. Just to reduce the amount of deposition in the back of the throat and also just to have better deposition to the lungs.
And
There's
if
another-
a
Go
yeah,
ahead, sir.
yeah, it's all right. If a teenager is doing well on their mild persistent asthma plan with ICS-BID and albuterol PRN, is there a need to switch them to SMART?
There's not a need, but if you want to reduce their overall inhaled steroid exposure and also have something that's maybe a little more effective, then I would recommend switching to SMART. I think that's something to kind of talk with the parents and just go the way the risk and benefits of, hey, you're doing well in this regimen, we can keep it on here. Or if we switch to this new regimen, it'll simplify kind of what you need to take for the day and also reduce the amount of inhaled steroids that your child is taking.
Anyone else want to add a chat question? Any other questions? All right. Thank you very much.
Thank you very much. Hope you guys have a good day.
All right. We appreciate your time. Bye
Thank you,
now.
everyone.